in Europe and in Asia and in the U.S. For about 5 years. And then I joined Baxter Healthcare. I always wanted to work in healthcare. I had a deep conviction in helping improve public health. And while I was there, I ended up beginning a strategy group. A lot of people with great strategic backgrounds like Julie, she can comment on. And we were able to work on a lot of the internal issues and opportunities in a way that was, we thought, more responsive and helpful to the company because we were part of it and knew the teams and could ensure lasting effect, and also, frankly, a whole lot less expensive than outside consultancies. So I joined there in 99, actually started in Vienna, Austria, post-merger integration of half of what was then Baxter Bioscience. Started creating the team. Julie joined shortly thereafter, and we'll talk about some projects in a second. But Julie, you want to do a quick intro?
Yeah, thanks, Brian. And very happy to be here with you as well. So I also started out in consulting and healthcare consulting, did that for just over 7 years before joining Baxter. And when people ask me about this transition, I always tell them that I didn't want to go to industry. I had this view of industry being very slow and bureaucratic, and, consulting was more fast-paced and interesting. But you convinced me, Brian. And so I joined Baxter. And since then, I had many different roles, different geographies. The company went through a spin-off, acquisition, and that's how I've landed here at Takeda. Today, I'm responsible for the U.S. business at Takeda.
Yeah, it's interesting. Julie and I and a few other great people that we've managed to get into the organization really were excited about applying the issues in healthcare. Baxter had some interesting questions around the economics of fractionating blood, and when one product's more in demand, how it affects others, and different supply chains for different geographies, and a lot of really interesting projects. Julie brought a tremendous amount of insights on the marketing and the sales side, and she really helped implement one of our most exciting projects. We'd gone through one of my early roles was they created a role for a head of e-business when that became a thing in the very late 90s, early 2000s. And we looked at across the whole value chain of opportunities. And one of them was compliance. And how do we increase compliance, and how can we leverage the then most advanced tools, which was essentially the internet. This is all pre-app, pre most of the technologies that we enjoy today. But we knew that we had the ability to leverage some technology to get to basically allow doctors that see patients, let's say every 6 months, to have a way of knowing when they're less compliant. And then when they know that, have the system do automatic prompts, to have people on their staff that are lower cost to be prompted to contact them. And it was a really interesting project that we took from sort of conception and idea to how do we apply it in a Baxter environment. And it was great having Julie because she's the one who was actually able to implement it. Can you comment on that a little bit, Julie?
Yeah, and maybe I'll give one specific example to bring it to life. One of the areas that we decided to implement this platform was in Taiwan. So this is a country that had really good standard of care for these patients, but for the first time was creating a comprehensive treatment center. And so they wanted to have this platform as part of how they manage their patients. And, as you said, this was before the time of apps and everything that we have today. So, the patients were being treated in hospital. So some of the challenges that you mentioned from a compliance standpoint didn't exist at the moment for them, but they wanted to be able to move to home treatment. But the concern was around the compliance and patients using the product appropriately and being able to report what they were experiencing when they were infusing the medicine. And so this platform was to be that bridge for them. And so implementing it in the center and figuring out how to have it interface with the hospital medical records, how to interface with the information that they needed to collect at home, and what if they didn't have an internet connection. And this was still back in the day where you had to use dial-up to connect, and so we had to have a parallel offline process for patients who either didn't have internet connection or had intermittent connection and therefore needed to bring in paper and then input all of the information onto the platform in the center. So it was trying to connect the digital world with the analog world, because we were at a time where we didn't have everything that we have available to us today. So I think it was a little bit ahead of its time, maybe.
Yeah. Well, I love your examples, because it reminds us, that the same problems that existed then exist today, right? How do you get data into a system? How do you allow people to enter the data once, as close to the system as possible? How do you do it in an efficient way? How do you do it in a way that doesn't prevent the provider from being a provider? And we were dealing with a lot of the same issues. Now, of course, we've got much more connectivity. Back then, we had far fewer tools. We had the internet. We were starting to try to leverage mobile tools. At the time, we had a Palm Pilot application where the Palm Pilot connected to a reader could begin to read some of the barcodes off the sides of in this case, it was hemophilia factor bottles. So, we were doing our best to leverage technology. And when you didn't have the real time, you had to have the offline, as you mentioned. So it was a fascinating project. It's probably worth mentioning, since we're at a HITLAB conference, the role of HITLAB in this. They were incredibly helpful, because as we were doing this and collecting the data, and Julie mentioned Taiwan, there was work being done in Canada, in the UK. They were able to collect the data, create the white papers, speak at some of the conferences, create awareness among different populations, diffuse, as we like to say. And it really made a difference, because we ended up having white papers that, eventually would turn into publications and greater awareness and greater credibility. So I think that's an important thing to add. And I guess it's also worth reminiscing a little bit about, how exciting it is to be where we are now. Because think, Julie, if we had AI, if we had the universal connectivity, if we had mobile phones, if we had apps, it's just amazing how much the technology landscape has advanced.
But I would say, though, some of the challenges I was mentioning, and as you rightly pointed out, still exist today. And if you look at, particularly from the lens of health equity, and let's just talk about the U.S.
Yes.
Most people think of the U.S. being such an advanced country, but as you and I both know, there are, whether it's healthcare deserts, internet deserts, all sorts of challenges across the U.S. in terms of being able to access all of this wonderful technology that exists today. So I think that's part of the challenge that we all need to figure out. How do we not leave people behind, so that as these advances in technology support better health outcomes, that it is being equitably accessed by everyone? And so I think we still need to think about, okay, yeah, great if you've got high-speed internet access and you've got access to all of these other tools, but if you don't, how do we make sure that those individuals can also stay connected and use all of the technology?
I'm really glad you brought that up, because you do remind us, all right, it's not just the technologies. Yes, the phones exist, the internet exists, but do you have a representative, sample of the population on the trial side, and then on the use and compliance? I'm currently on a board with a company called the Health Tree Foundation, and they worked very hard to get patients to be willing to share data such that it would be available to other patients. They started in myeloma, but the idea is that, I can find a like-minded person, or a person similar to me, right? If I'm refractory to this, I'm this age, this gender, try these sorts of medications, what would the people at Stanford, Harvard, different doctors in different places say? And they literally did like a 50-state tour, going and talking to patient groups and getting them to put their data in. But in the end, you do end up with, it's predominantly, people of a single ethnicity. And so part of the, and as you know, there's more and more of an emphasis, not just in the provision of care, but also in the doing trials to make sure that we are better demographically represented. And so we're making a lot of efforts to reach out and to include other, a broader array of better representation. And it's challenging, right? Because there's different levels of trust. It's not just, it's access, it's trust, it's awareness, it's a lot of aspects.
Exactly. And I do think we need to think about that whole environment, that whole ecosystem, when we think about how do we continue to innovate and create more digital health technologies to support better health for people. And so this is, I think, the ask of the crowd that's listening to this is, don't just think about the technology itself that you're trying to develop. Think about the whole environment that technology needs to sit within, and how you can create equitable access to that technology. And also, the other hot topic these days around data privacy, et cetera, make sure that you've got all of the right security built in to protect individuals as they interface with whatever it is that you create.
Well put. I think this issue raises an interesting one. Is how do we make sure technology is really inclusive, and how do we get better representation? It's an issue. As I mentioned, we saw it we see it with Health Tree Foundation in the myeloma cancer space. I know when I worked with the Diabetes Association, it was also a common issue. It really requires being thoughtful about how do different groups of people, different ethnicities, how do they think about healthcare? How is it provided? Who do they trust? Right? Who do they look to? And I think it's a challenge for the whole pharma industry to, get patients comfortable that data is being used responsibly and in their best interest. I'm from the pharma industry, so I think that a lot of the biases, as you are, I think a lot of the biases are historic and probably not necessarily valid in this day and age, but they exist, right? And perception is reality, and we have to work through it.
Yeah, and I think it's incumbent upon all of us to be aware and to each do our parts, but recognize that this is a big, complex problem that we can't necessarily solve as individuals or as individual companies. And so reaching across and working, with others is going to be the approach that we'll have to take. And so, again, I'm sure there's lots of people out there in the audience who come from a variety of different angles. I would just also encourage you to collaborate, because I think that's the way that we'll be able to get some traction and to address some of these challenges. Because let's face it, the technology is going to continue to advance much faster than things like regulation and policies and whatnot. So we've got to do it responsibly. And agencies like the FDA and others around the globe, they'll be in constant catch up, I believe, going forward.
I think that's right. Well, Julie, I think you've issued a good challenge to all of us. So Stan and the HITLAB team, and everyone there at the conference, we hope things go well, and we hope that you're able to make significant advances along the digital continuum, as well as, attitudes and access, as we've discussed. So have a great meeting.